Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I am here with our in-house toxicologist, Dr. Sanjay Mohan. Sanjay, welcome back.
How's it going, Swami? It's been a little bit, but now that our interns are settled and we're well into the academic year.
Yeah. Listen, we took the summer off. Unfortunately, emergency medicine and toxicology does not take the summer off, and we got lots of stuff to get into. And what we're going to dive into today kind of toes the line between toxicology and just general emergency medicine, but it is such a critical piece. And we're diving into the QT segment. This is one that the emergency cardiologists love, the toxicologists love. Everybody loves the QT segment. And you're going to give us a little bit of the basics, but then we're really going to get into some of the nuances of why it's so important, why we need to be paying attention to it. But again, let's start basic. What does the QT segment represent?
The QT interval is the middle child of the EKG family. It is often ignored, underanalyzed, and just honestly probably forgotten more than most. It's one of those things where if the perfect patient comes in the right clinical scenario and you don't look at that QT interval, it's going to burn you. The QT interval reflects the time from ventricular depolarization and contraction through ventricular repolarization and relaxation.
Super important when it is important, which is why we need to really understand it. So the main thing that we are looking at when we look at an ECG is the corrected QT or the QTc. And usually what we talk about is looking for QTc prolongation. So let's talk about definitions. What defines a prolonged QTc?
So the QT interval must be interpreted in conjunction with the patient's native heart rate. The QT interval shortens in the context of tachycardia and lengthens in the context of bradycardia. Or in other words, tachycardia is protective when evaluating the patient with prolonged QT. So with that in mind, many EKG machines will calculate a corrected QT interval or QTc. And the QTc is really a standardized way to account for variations in heart rate so that clinicians are able to compare QT intervals at different heart rates over time and thus calculate risk. Now, there's a variety of correction formulas. Bazette's, Fredericia, Hodges, Framingham, Radharaju. They all have pros and cons, but at the end of the day, the vast majority of clinicians, and I know you know this, Swami, are just going to read the EKG machine and kind of go with that.
Yeah, I think that's true. I think we are going to use that when we're looking at abnormal numbers or normal numbers. What defines normal and abnormal for that QTc?
So generally, a QTc is considered prolonged if greater than 440 milliseconds in males or 460 milliseconds in females. Once the QTc gets greater than 500 milliseconds, the risk of ventricular dysrhythmias increases 2 to 3-fold.
So 500 is really the cutoff that we are looking at. Like, yes, 450 in a man is abnormal, but we don't really start to get worried about it until we see that 500 number. That's when we start to get really worried about it in both men and women. Can I use the computer ECG reading for the QTc, or do I really need to do the calculation on my own? And Sanjay, I'm just going to say to start with, I've done a lot of math in my time. It's been a long time since I took a math course, and I really don't want to do the math. I really want to rely on the computer.
Frankly, I don't want you doing the math either, Shani. You're trying to poke the bear. I know what you're trying to get me to. Look, a lot of us work in high volume, high acuity emergency departments. I'm an ER doctor, just like all of you guys. I don't often manually calculate the QT, but if I'm concerned from a QT standpoint, the patient has, refractory nausea and vomiting, hypokalemia, hypomagnesemia, I'm possibly giving them Zofran, then I'm going to manually calculate it. I will tell you that the paper speed and sensitivity will alter readings. Higher paper speed will lead to shorter interval values, and higher machine sensitivities can result in QT prolongation. And look, I can't even tell you the last time I even thought of paper speed on my EKG machine. So it's really tailoring your practice to the patient sitting in front of you.
This is really important because, yes, from a really genuinely honest approach, it is better to calculate every QTc than it is to use the computer reading. But from a pragmatic approach, none of us are going to do that. On an average shift, I might see 25, 30, 35 ECGs. I can't calculate the QTc on all of those. All I would be doing is calculating QTcs. So we do have to rely on the computer. Really, this is a call for the computer programming to get better, to give us an accurate QTc. That's really what we want. But when you have the scenario where you're like, this could really change what I do, somebody with recurrent syncope, that might be a case where I'm like, you know what? I'm going to have to calculate this QTc on my own, especially if it's like right around 500. Like if it's 480 and I'm like, oh, if this was actually 500, it would make a big difference of what I was thinking about for this patient. So those are situations where I might slow down and really do that calculation. But otherwise, we would grind the ER to a halt if we were calculating this on every single patient. Sanjay, you alluded to this, but I think we should really dive in here. What's the clinical relevance of the prolonged QTc?
Right. So pardon my French, but clinically, QT prolongation increases the risk of torsades de pointes, a form of polymorphic ventricular tachycardia, a non-perfusing rhythm that is classically described as a pattern of twisting points or alternating amplitudes. This occurs when a premature ventricular contraction, or a PVC, leads to an RNT phenomenon during the repolarization period.
This is the critical thing. This is why we care about QTc prolongation. It's because of that potential for torsade de pointe. What are some of the common causes of a prolonged QTc? Which, listen, I know this is a long list, but let's just talk about the most frequent ones that we're going to consider in the emergency department.
As you said, Swami, the differential for QT prolongation is super long. There's congenital long QT, electrolyte disturbances such as hypokalemia, hypomagnesemia, hypocalcemia, hypothermia, myocardial ischemia, and increased intracranial pressure. Moreover, there is a whole host of xenobiotics that can prolong your QT interval.
Well, like you said, there's a lot of medications, and this is one of the really important ones. I mean, listen, hypo-K, hypomag, hypocalcemia, all of these things are important causes of QT prolongation, but often we come back to those medications. So how about a little bit of a short list, common medications we run into in the emergency department, or even that we might be prescribing that are high risk for prolonging the QT?
So, as a toxicologist, whenever I get this question from my residents, I often joke everything and anything prolongs your QT. There's actually a website, crediblemeds.org, that if you go to, will actually tell you a list of QT prolonging medications. But as ER clinicians, these are the ones that kind of perk my ears up. Antipsychotics, things like haloperidol and olanzapine, fluoroquinolones like ciprofloxacin and levofloxacin, macrolides, azithromycin, erythromycin, antiemetics, Zofran or ondansetron, and then one in particular is methadone. Particularly because not only does it inherently prolong your QT, but it induces a bradycardia. So it's kind of like a double hit that will increase your risk of torsades.
Some of these medications are ones that we're giving on the daily, right? Ondansetron, I can't remember a shift I went without writing for that medication. Even things like haloperidol and some of those antibiotics are commonly prescribed in the emergency department. So, do we need to get an ECG on every patient prior to giving a dose of something like ondansetron?
So this is kind of one of my soapbox speeches, Swami, and I know you'll love this, given that we're both Bellevue alumni. So at least when we were both there, I could tell you this was a patient that occurred once every 12 months, every 18 months. Who was the patient that got torsades? It was that patient that was on methadone, was vomiting their brains out. They were hypo-K, hypomag, hypocalcemic, happened to have pneumonia, got admitted. The medicine team gave a Zithro, and while they're boarding in the ED, what happened? Bam, torsades. The way I kind of frame this to my trainees is that torsades is the perfect ER kind of paradigm. We're operating on probability. If a young patient comes to me, they have no medical problems and they're vomiting their brains out, I'm more than happy to give them 4, 8, 12 milligrams of Zofran. But if that right patient comes and we're stacking risk factors, that's when you should be scared. They're on methadone, they're bradycardic, we know they're hypo-K, we know they're hypomag. Yeah, then at a certain point, you probably should be getting a screening EKG to make sure they don't have prolonged QT.
Yeah, this is really important because we don't have to get it on every patient, but we have to be able to select the patients that are higher risk that we really want to get it on. The patient who is on methadone, who's vomiting, who has all of the electrolyte risk factors, we can get an ECG on them before we give them one of these medications. I don't think it's that big a deal. The one that kind of gets a little bit tricky is the agitated patient where we're writing for something like haloperidol. It's hard to get an ECG on an agitated patient. There is some literature in this space saying that, you know what, you're not going to be able to do it. You're not going to be able to get a reliable ECG, get the patient sedated, and then get the ECG and see what the risk is. And this is particularly important if you're writing for multiple doses. So if you give one dose of haloperidol, you're probably really not going to get into that much of trouble. But if you're writing for a second or third dose, you got to get that ECG before you're writing for that second or third dose. Or if you're giving someone something like levofloxacin and you're giving them ondansetron, come on, man, just get the ECG, make sure it's not a big problem. But on the 19-year-old who comes in with gastroenteritis and they're vomiting, you probably don't need to get it. I think that's really important for us to balance the risk and then say, this is a high risk patient. Let's get the ECG first before I make my decision. Now let's pivot to managing that torsade should it develop. If you have that patient where you put them on levofloxacin for their pneumonia, You gave them a couple of doses of ondansetron. Then they became agitated and you gave them haloperidol. They go into torsade. How are we managing that? What's the first thing we're reaching for?
So it's funny, Swab, at least in my experience, and I feel like you may have had a similar, whenever you talk ACLS with medical students or residents and you say torsades, everybody knows the buzzword, magnesium, magnesium, magnesium. But let's play this in real time. Patient loses their mental status, is now hypotensive, and you see torsades. Don't be the guy or the girl that says, let's give magnesium. Shock that patient. That is a non-perfusing rhythm. You need to defibrillate that patient as fast as possible. Magnesium is really to prevent that next early after depolarization.
Right. So this is really important. It's not the magnesium, it's shock first, and then you can load them with magnesium. This is really important. I think it often gets done wrong or thought about incorrectly. Like you said, it's a non-perfusing ventricular dysrhythmia. Shock them and then figure out afterwards what's next. After the conversion, you want to get an ECG because you might not have noticed that prolonged QTc before. Let's say that we have a patient, they're in torsade, we shock them, and their QTc is 600. What's the next steps that you are doing?
Realistically, it's prevention and figuring out why their QTc is 600, right? So the first thing I would do is assuming you have lab work, go back to your computer, see if anything's funky. Are they hypokalemic, hypomagnesiemic, hypocalcemic? And if so, please replete. Are they on medications that you could stop, right? Are they on azithromycin? Are they on antipsychotics? At this point, it's really about kind of backtracking and figuring out, hey, what has this patient been given? And I should stop that in order to prevent further risk of ventricular dysrhythmias.
How about if we see a patient with prolonged QTc that's asymptomatic? They didn't come in for syncope, they haven't had torsade. What kind of a workup should we be initiating in the emergency department?
Oh man, this is like $1 million question, Swami. I don't think there's a right answer for this, right? I could tell you that, as you said, if there was a suspicion of lightheadedness or syncope or slash vertigo, what have you, I think it's your obligation as an ER physician to poke a little bit further. Maybe, admit them to your syncope obs or your chest pain obs. But if they're truly asymptomatic, do the simple things first, right? Get a set of electrolytes, ask them what the medications they're on, do a good medication reconciliation. But if they're truly asymptomatic, and the QT is not terribly prolonged, I know that's a little hand wavy. I can't give you a good answer. I think it's reasonable, assuming they're truly asymptomatic and reliable and health literate, to be like, hey, you should probably follow up with a cardiologist relatively soon.
Yeah, I've asked this question to many people, including Amelman too. And he said, if they're completely asymptomatic, get your lights, do your med rec. If there's nothing there, if their potassium's normal, their magnesium's normal, their calcium's normal, their medications aren't ones that prolong the QTc, and they're completely asymptomatic, you can probably send them for follow-up, but there's some QTc number that makes us all kind of antsy, right? If it was 800, you'd be like, nah, I'm not sending that patient home. So what is that threshold? Nobody really has an answer. Somewhere around 600 to 650 seems to be where most people kind of congregate. Like if it's over 600, I'm probably going to keep them at the absolute minimum. I'm going to talk to my cardiology team about the patient and come up with a solid plan for getting the patient followed up. Honestly, sometimes the cardiology team is like, I don't like 600 either. Put them on telly. We'll see them in the morning and we'll figure out what's next. I think once you hit some magic threshold where you become a little bit anxious about it, just involve the specialist, figure out a good plan, and that's a fine way to move forward. But obviously, if they have electrolyte abnormalities or medication problems, you can fix those, right? We can replete the potassium, we can replete the magnesium, we can stop the medications that are the problem. All of those things are important to do. And remember, like you said earlier, all of these things can be the problem together. So it can be electrolytes and medications, and the patient can have a congenital abnormality. Sometimes, even after you fix everything, the patient still has a prolonged QTc. They need extensive workup from your cardiology team, things that we're not doing in the emergency department. All right, Sanjay, let's wrap up with some big take-home points about QTc prolongation.
The QT interval reflects the time from ventricular depolarization and contraction through ventricular repolarization and relaxation. Clinically, QT prolongation increases the risk of torsade de Pointes, a form of polymorphic ventricular tachycardia that is classically described as a pattern of twisting points or alternating amplitudes. This occurs when a premature ventricular contraction leads to an RNT phenomenon during the repolarization period. The differential for QT prolongation is long and varied. Congenital reasons, electrolyte disturbances, hypothermia, myocardial ischemia, and increased intracranial pressure. Moreover, a whole host of xenobiotics can prolong the QT interval. If a patient happens to fall into torsades, initiate ACLS with immediate defibrillation and magnesium. At the end of the day, withdrawing offending agents and correcting electrolyte abnormalities is what's best.
All right, that's all for the Rebel Core Content podcast this week. We'll be back in a couple weeks for another cast. And in the meantime, don't forget to check out all of the fantastic posts on our website. And until next time, stay safe.